Welcome to the Deep Dive. Today, we're stepping into a world where every second counts, and the smallest individuals demand the biggest care. Imagine a newborn, barely a few pounds, whose body isn't quite ready for the world outside, or perhaps one struggling with challenges that began even before birth.
It really is a realm of incredible fragility, yes, but also astounding resilience, and is all supported by this highly specialized, very precise care.
What's truly remarkable in this field is how a seemingly minor detail in a tiny infant can signal a profound underlying vulnerability. That journey from the womb to thriving outside is just so intricate.
Absolutely. And for some newborns, it requires a level of intervention, a level of precision that I think many people might not even realize is happening behind the scenes.
Definitely. Our deep dive today is into this complex, often intense world of high-risk newborns. Our mission really is to understand those critical nursing assessments made right from the start.
Right. And the vital interventions that can make such a difference. We want to get a sense of the dedication behind their care.
Exactly. We'll explore the unique challenges tied to a baby's maturity and size, look into how a mother's health can influence her newborn,
And unravel things like jaundice, navigate those various respiratory issues.
and discover key interventions like, preventing cold stress. By the end, you should have a much clearer picture of what it truly means to care for these incredibly strong, tiny fighters.
Let's unpack this. So to begin, the term high-risk newborn sounds quite serious. But what exactly puts a baby into this category? I mean, aren't all newborns delicate in their own way?
That's a great question, and it's a really critical distinction. While, yes, every newborn is delicate, a high-risk infant is one facing complications either right at birth or shortly after, complications that significantly threaten their survival or their long-term health.
Okay.
We tend to group these challenges broadly. Sometimes it's about their maturity, how early they arrived. Sometimes it's their size. Sometimes it's maternal factors stemming from the pregnancy itself. And sometimes it's congenital issues they're born with. It's truly a spectrum of vulnerability. That makes sense, seeing it as a spectrum. So, with this range of possibilities, how do nurses even begin to identify these infants, especially in those crucial first moments after birth? What are the immediate signs they're looking for? This relates directly to that first objective, right? Describing assessments that identify high-risk newborns.
Exactly. The initial assessment is all about rapid observation. Think about the APGAR scores, that quick check done at 1 minute and 5 minutes after birth.
Right, the one that looks at heart rate, breathing.
Precisely. Heart rate, breathing effort, muscle tone, their reflex irritability, how they react to stimulation, and their color. It gives a quick numerical snapshot.
But it's more than just the score.
Oh, absolutely.
Yeah.
Beyond that number, nurses are observing the quality of the baby's first cry. Is it strong and robust, or is it weak, maybe high-pitched? What's their overall color? Are they nice and pink, or do they look a little blue, maybe dusky? And how active are they? Are they moving vigorously, or are they limp?
So a strong cry, good tone, pink color, those are good signs.
Very reassuring signs. Any deviation from that immediately raises a flag, signals the need for a closer look for further investigation.
Okay, that's the quick scan. But then there's the more detailed physical assessment. What specific physical clues are they looking for that signal risk, particularly thinking about problems related to a baby's maturity?
Yeah, maturity is a huge factor. Prematurity, meaning an infant born before the 37th week of gestation, is a major risk factor. And fundamentally, the earlier a baby arrives, the greater their risks are across the board.
What kinds of risks are we talking about?
Now, premature infants might face significant breathing difficulties, struggle to regulate their body temperature, they're much more prone to infections, or they could even have bleeding in their brain. The degree of prematurity, how early they are, really dictates the potential severity of these challenges.
It sounds like the earlier they are, the more fragile they might be. Are there different classifications for preterm infants based on their weight?
Yes, absolutely. We classify them into different weight categories, which often correlates with their gestational age and risk.
Yeah.
So low birth weight is anything less than 2,500 grams, which is about 5.5 pounds.
Okay.
Then there's very low birth weight, which is less than 1,500 grams, or roughly 3.3 pounds.
Wow, tiny.
Extremely low birth weight. These are the smallest babies, less than 1,000 grams, which is about 2.2 pounds. The general rule holds. The smaller the weight, usually the earlier the birth, and therefore the higher the risk profile.
That weight distinction really highlights the vulnerability. But
Yeah.
here's something interesting. You mentioned the paradox. What physical characteristics might be considered normal for a preemie, but actually tell nurses, okay, this baby is profoundly immature and needs very specific care?
That's where the skilled nursing assessment really comes in. While these findings are expected or normal for their gestational age, they are absolutely flags for immaturity and potential risk. For instance, premature infants often have very smooth foot bottoms, maybe just a few creases, which indicates underdeveloped skin layers.
Compared to a term baby with lots of creases.
Exactly. Preemies tend to have more lanugo, that fine, downy hair, sometimes covering much of their body. Their muscle tone is often hypotonic, meaning they tend to lie in a more extended kind of floppy position, less flexed than a full-term baby.
A little less curled up.
Right. Their ears might be very soft and fold easily because the cartilage hasn't fully developed yet. For babies born very early, say before 26 weeks, their eyelids might even still be fused shut.
Really? Fuse?
Yeah. They might also have more vernix caseosa, that white, creamy coating on the skin. If it's a boy, undescended tests are common. Their reflexes, like sucking or grasping, can be diminished or even absent. The bones of their skull might feel slightly overlapping because they haven't fused yet, and their cry is often weak, maybe high-pitched. Each of these findings, while normal for that age, is a crucial piece of the assessment puzzle, telling the nurse about the infant's developmental stage and their specific needs.
That's an incredible level of detailed observation. So, once prematurity is identified based on these assessments, what are the immediate nursing actions and the broader medical approaches?
For premature infants, the first priority is often resuscitation and stabilization if they're struggling at birth. This is immediately followed by a very thorough physical assessment to identify all their needs: respiratory, thermal, nutritional, everything.
And the family?
Absolutely vital. Providing sensitive psychosocial support for the family is key. They're often experiencing immense stress, fear, maybe shock. Medically, sometimes mothers might receive corticosteroids before delivery if preterm birth is anticipated to help the baby's lungs mature faster.
Ah, okay.
Then for the infant after birth, ongoing needs almost always include respiratory support of some kind, IV fluids and medications, and specialized nutrition. Often, this nutrition has to be given parenterally, directly into the bloodstream, through central lines or umbilical lines, because their digestive system just isn't ready for oral feeding yet. These interventions directly address those problems related to maturity we were talking about.
Okay, that gives us a good picture of prematurity. Now, let's shift to problems related to a baby's size. This is another objective understanding interventions for maturity or size. What does it mean for an infant to be small for gestational age, or SGA?
SGA means a baby is born with a birth weight that falls below the 10th percentile for their specific gestational age. It's not just about being small, it's about being smaller than expected for how long they were in the womb.
And does it always look the same?
Not necessarily. This can manifest in two main ways. It can be proportional, where all their body measurements, head, length, weight, are small. Or it could be disproportional, where, for instance, their head might be a more normal size, but the rest of their body, particularly their weight, is notably smaller.
What causes a baby to be SGA? Why might they not grow as expected?
The reasons often involve anything that restricts growth in the womb. Common causes include problems with the placenta. Maybe it wasn't delivering enough nutrients or oxygen, what we call placental insufficiency. Maternal infections can play a role, as can maternal smoking, high blood pressure, malnutrition, or substance abuse. Even having multiple pregnancies, like twins or triplets, can sometimes lead to SGA.
And when nurses are assessing these SGA infants, what do they typically see?
During assessment, SGA infants often appear with loose, dry skin. They have very little subcutaneous fat or muscle mass. They might have sparse scalp hair and often a weak-sounding cry. Critically, they are particularly prone to cold stress, hypothermia, and also hypoglycemia, or low blood sugar.
You mentioned placental insufficiency. Is there a related term, IUGR? How does that fit?
Yes. Intrauterine growth restriction, or IUGR, essentially describes the underlying condition or process that causes the baby to be SGA. It's the why behind the small size. And we typically see two main patterns of IUGR. There's symmetric IUGR. This means the baby is uniformly small, weight, length, and head circumference are all proportionally reduced, typically below the 10th percentile. This often points to problems that started earlier in pregnancy, maybe during organ development, like severe congenital infections or exposure to certain toxins or significant maternal stress.
And the other type?
The other is asymmetric IUGR. This is different. Here, the baby's length and head circumference might actually be appropriate for their gestational age, or closer to normal, but their weight is significantly below the 10th percentile. This pattern usually indicates problems occurring later in pregnancy. Things like placental insufficiency, preeclampsia, or severe maternal malnutrition, It suggests the baby's body adapted by prioritizing blood flow and nutrients to the brain, sometimes at the expense of body weight and fat deposition.
Ah, so the pattern tells you something about when the growth restriction might have started.
Exactly. Nurses assess for these different patterns because they point towards different underlying causes and potentially different associated complications.
So, for an SGA infant, what are the critical nursing interventions? Thinking again about that objective related to maturity or size problems.
Nursing care for an SGA infant is really focused on managing the risks associated with their restricted growth. Nurses might use specific tools, like the Ballard score, to accurately confirm the baby's gestational age, because sometimes dates can be uncertain. They're extremely vigilant in assessing for any signs of respiratory distress and looking for any obvious congenital anomaly.
And temperature.
Absolutely. A cornerstone of their care is meticulous thermoregulation to prevent cold stress. These infants are very susceptible due to their lack of body fat. This directly addresses another key objective: identifying interventions to prevent cold stress.
Right.
A critical intervention is preventing hypoglycemia. Low blood sugar is a major risk. So early and frequent feedings are essential. Nurses will monitor blood glucose levels closely. They also track daily weights and observe very carefully how well the infant tolerates those feedings.
Now let's flip to the opposite end of the size spectrum. Large for gestational age, or LGA. What defines that and what are the main concerns there?
LGA means a birth weight above the 90th percentile for their gestational age. So a significantly larger baby than expected. While the exact cause isn't always known, the most well-recognized association is with infants of diabetic mothers, or IDM, which we'll talk more about later.
What are other risk factors besides maternal diabetes?
Other risk factors can include mothers who've had many previous pregnancies, a history of having large babies before, or pregnancies that go significantly past their due date post-term pregnancies.
So, what specific things do nurses look for when assessing an LGA baby beyond just their large size?
Nurses meticulously assess for signs of birth trauma. This is much more common with larger babies, simply due to the mechanics of delivery. We're thinking about things like a fractured clavicle collarbone or nerve damage in the shoulder area from potential shoulder dystocia, which is when the shoulder gets stuck during delivery.
That sounds painful.
It can be. Herb Duchenne paralysis is one type of nerve injury we look for. Hypoglycemia, low blood sugar, is also a major concern, particularly, as I mentioned, in infants of diabetic mothers. Nurses also look for signs of polycythemia.
Polycythemia.
That means having too many red blood cells. It can make the baby look very red or ruddy. It happens sometimes as a response to mild chronic hypoxia in utero. And these infants are also at increased risk for hyperbilirubinemia or jaundice,
Why jaundice?
often because of the increased breakdown of red blood cells, either from the polycythemia itself or from bruising related to a difficult or traumatic delivery. More broken down red cells means more bilirubin for the immature liver to handle.
So, for LGA infants, what are the crucial nursing actions?
Nursing actions focus squarely on managing these specific risks. That means a thorough assessment of their respiratory status and checking very carefully for any signs of birth trauma, looking for asymmetry of movement, crepitus over the clavicle. It's also vital to closely monitor blood glucose levels, often requiring early and frequent feedings to keep those sugar levels stable. Nurses will also monitor hemoglobin and hematocrit levels if polycythemia is suspected, and keep a very close eye out for any developing signs of jaundice.
We've covered premature SGA and LGA. What about babies who are late? We mentioned post-term pregnancy as an LGA risk factor, but how are post-mature infants themselves considered high risk?
Right, post-mature infants are those born after 42 completed weeks of gestation. Risk factors might include a history of previous post-term deliveries, being a first-time mother, or interestingly, grand multi-parity, having had many previous pregnancies.
And why are they high risk? Does the placenta cause issues?
That's often the core problem. The placenta often starts to age and function less efficiently after 40 weeks. This placental insufficiency can lead to a number of serious complications. While some post-mature infants might be LGA, or even macrosomic, meaning excessively large, the declining placental function increases risks like meconium aspiration.
Because the baby gets stressed.
Exactly. Fetal hypoxia or lack of oxygen can occur. There are risks of neurological complications, hypoglycemia because they might have used up their reserves, hypothermia due to depleted fat stores, and also polycythemia, paradoxically, sometimes as a response to chronic low oxygen levels.
And what do these post-mature infants typically look like during the nursing assessment?
They often have a distinct appearance. They usually lack Vernix caseosa, that creamy coating, and have minimal ludo, the fine hair. Their skin is often very dry, peeling, and may even look cracked or leathery. This is partly due to the loss of subcutaneous fat as they metabolize their reserves in the womb because the placenta isn't keeping up.
So that also explains the hypoglycemia risk.
Precisely. They have very little subcutaneous fat overall, contributing to that dry appearance. Critically, their skin, fingernails, and umbilical cord might be stained a yellow-green color from meconium if they pass stool into the amniotic fluid before birth. You might also notice they have quite long fingernails, and sometimes even scratches on their face from them.
What are the key interventions for post-mature infants?
Interventions primarily involve heightened vigilance and supportive care. Nurses assess immediately and continuously for any signs of hypoxia. They check carefully for the presence of meconium staining and are prepared to intervene quickly if aspiration is suspected. They look closely for any birth injuries, which can happen due to the baby's potentially large size and the reduced cushioning from lack of vernix.
And blood sugar, temperature.
Yes, rigorous assessment and monitoring for hypoglycemia are essential. This includes blood glucose checks and initiating early feeding. Maintaining a neutral thermal environment is also crucial because, as we said, their limited fat stores make them very susceptible to cold stress.
So many variables influencing these tiny lives. Now let's pivot slightly to a crucial, overarching intervention that applies to many of these high-risk categories we've discussed, especially preterms and SGA infants. That's preventing cold stress. Why is keeping a newborn warm so critical? This is a major nursing objective.
It is absolutely fundamental. Newborns, particularly those who are premature or SGA, are incredibly susceptible to cold stress. There are several physiological reasons for this. They have a very large surface area compared to their body mass, which means they lose heat to the environment much more quickly than an adult or even an older child.
Okay, that makes sense.
They also lack the insulating layer of subcutaneous fat that adults rely on. Their muscle mass is small, so they can't generate much heat through activity.
Okay.
And crucially, newborns cannot shiver to generate heat like adults can. Their sweating mechanism isn't fully developed either, so regulating temperature is just inherently difficult for them. Their heads, in particular being relatively large, are a major source of heat loss.
That paints a clear picture of why they're so vulnerable. So, what are the concrete nursing interventions to prevent cold stress or to manage hypothermia if it does occur? Let's really focus on this objective.
This is a cornerstone of neonatal nursing care. Nurses work diligently to maintain what's called a neutral thermal environment. This often means using a radiant warmer overhead or placing the baby in a special double-walled incubator, often called an isolette.
So, controlling the environment.
Yes, and everything that touches the baby. All equipment, the oxygen they breathe, any linens used must be pre-warmed. It's absolutely vital to ensure the infant is immediately and thoroughly dried after birth and after any bathing. In fact, often the first bath is postponed until the baby's temperature is completely stable.
Simple things, too.
Very important simple things. Immediate skin-to-skin contact with the mother right after delivery is incredibly effective for thermal regulation. If that's not possible, placing the baby directly under a radiant warmer is the next step. Nurses continuously monitor the baby's axillary temperature, usually every couple of hours or more frequently if needed, aiming to keep it stable, typically above 97.6 degrees Fahrenheit or 36.5 Celsius.
What about clothing?
Putting a hat on the baby's head is essential because of the heat loss there, and wrapping them snugly in warm blankets helps conserve heat. It's also critical to assess their oxygenation status and check for hypoglycemia, because cold stress actually burns through glucose stores and increases oxygen consumption, making low blood sugar much more likely.
And if a puppy does get cold?
If rewarming is necessary, it must be done slowly and carefully to prevent complications like hypotension, low blood pressure, and apnea, or pauses in breathing. Rapid warming can be dangerous. Finally, infants are only transitioned out of an incubator or warmer into an open crib when their temperature regulation is consistently stable and they are gaining weight appropriately. These interventions are absolutely vital in preventing cold stress and its dangerous consequences.
Okay, let's take a deep breath ourselves now and move into the critical area of respiratory challenges. It's hard to imagine anything more vital than breathing, especially for a newborn, and this is another major objective, discussing nursing care for newborns with respiratory distress.
Absolutely. And sadly, respiratory distress is the most common cause of death in preterm infants. One of the conditions we see most frequently, particularly in babies born prematurely, is respiratory distress syndrome, or RDS.
And RDS, the core problem there is surfactant, right?
Precisely. Surfactant is that substance lining the alveoli, the tiny air sacs in the lungs, that keeps them from collapsing when you exhale. In RDS, the baby doesn't have enough surfactant, usually due to lung immaturity.
So the air sacs just collapse.
They collapse with each exhalation, making it incredibly difficult for the baby to inflate them again with the next breath. It takes enormous effort. Add to that the fact that premature infants have lungs that simply aren't fully developed. They have fewer and less mature alveoli for gas exchange anyway, and their chest wall muscles are weak, meaning they can't easily reposition themselves to keep their airway open if needed.
When does RDS usually show up?
Signs of RDS typically develop either immediately at birth or within the first hour or two afterwards. The severity is almost always directly related to how premature the baby is. Surfactant production really only starts ramping up around 24 to 26 weeks of pregnancy and isn't considered complete until about 37 weeks.
But we can give surfactant now.
Yes. Fortunately, we can administer synthetic or animal-derived surfactant directly into the baby's lungs via an endotracheal tube after birth if they need it. It can make a huge difference.
So what does RDS actually look like? If a nurse is assessing a baby, what are the key signs they're observing?
The signs can be quite dramatic and clear. Early on, you'll notice tachypnea, a very rapid breathing rate, often well over 60 breaths per minute, which is the upper limit of normal for a newborn.
Okay, fast breathing.
Yes. And visible retractions. That's where you see the chest wall, maybe between the ribs or under the sternum, pulling in sharply with each breath because they're using accessory muscles to try and get air in.
What else?
You might also see a distinctive seesaw breathing pattern where the chest and abdomen move in opposite directions. You can often hear an audible expiratory grunting sound. That's the baby trying to keep the air sacs open a little longer by partially closing their glottis. And you'll likely see nasal flaring, where the nostrils widen with each inhalation, another sign of increased work of breathing.
And oxygen levels.
Their oxygen needs will be increased just to maintain normal levels in the blood. Their skin color might appear gray or dusky, indicating poor oxygenation. If you listen to their lungs with a stethoscope, breath sounds are often diminished, and as RDS progresses, you might hear crackles.
How do they seem otherwise?
Neurologically, these babies might be lethargic, kind of floppy, with poor muscle tone. Lab tests often show hypoxemia, low oxygen in the blood, and often acidosis as carbon dioxide builds up. They'll also likely have tachycardia, a heart rate over 160 beats per minute, especially if they're struggling with acidosis and low oxygen. Very concerning late signs would be worsening lethargy and periods of apnea where they stop breathing altogether.
That sounds incredibly stressful for the baby, the family, everyone involved. What is the nursing care like for an infant experiencing RDS? This is central to that objective.
Nursing care for RDS is intense, continuous, and requires constant vigilance. Nurses monitor respirations constantly, aiming to keep the rate ideally between 30 to 60 breaths per minute, assessing maybe every hour or two, or even more frequently if the baby is unstable.
And oxygen.
They meticulously assess oxygenation status and administer oxygen as ordered. This might be via a small plastic hood over the head, a nasal cannula, or if things are severe, mechanical ventilation through an endotracheal tube. Auscultating breath sounds frequently and continuously monitoring for any worsening signs of respiratory distress. Increased retractions, grunting, color changes are paramount.
What about secretions?
Suctioning as needed is important to help maintain a clear airway, but it has to be done carefully to avoid causing more distress or drops in oxygen. Oxygen saturation levels and arterial blood gas results are closely tracked to guide therapy.
Does positioning matter?
Yes, positioning is also key. The baby's head should usually be slightly elevated, maybe in a supine sniffing position, to align the airway. Interestingly, sometimes a prone or belly-down position can actually help improve chest expansion and oxygenation in some infants. And maintaining that neutral thermal environment we talked about is absolutely crucial here, because getting cold would only increase their metabolic rate and oxygen demand, making the respiratory distress worse.
You mentioned feeding earlier with high respiratory rates.
Right, a critical point for nursing care. If the infant's respiratory rate is consistently greater than 60 breaths per minute, oral feedings are typically withheld. The risk of aspiration, inhaling milk into the lungs, is just too high when they're breathing that fast and working that hard. They would likely receive nutrition intravenously instead.
Beyond the immediate crisis of RDS, what are the longer-term complications? It sounds like these early respiratory struggles can potentially have lasting impacts.
They absolutely can. Acute complications that can happen during the RDS episode itself include things like a pneumothorax, a collapsed lung, infection, intraventricular hemorrhage, that bleeding in brain we mentioned earlier, and patent ductus arteriosus, or PDA, where that fetal blood vessel fails to close properly after birth, putting extra strain on the lungs.
And longer term.
Long term, the two main concerns we often see stemming from severe RDS and its treatment, especially prolonged oxygen and ventilation, are bronchopulmonary dysplasia, or BPD, which is chronic lung disease, and retinopathy of prematurity, or ROP, which affects vision development.
Okay, let's talk about bronchopulmonary dysplasia, BPD then. Since it's a significant long-term respiratory challenge, what exactly causes it?
BPD is essentially chronic lung disease that develops in some infants, mostly preemies, who have needed prolonged respiratory support. The main risk factors are needing oxygen support for more than 28 days, often coupled with requiring mechanical ventilation. Extreme prematurity itself is a huge risk factor, as is having had severe RDS initially. Exposure to high levels of oxygen, which can actually be toxic to the delicate developing lung tissue, and the inflammation caused by ventilation and sometimes infection all contribute. Essentially, the lungs get injured and don't heal properly, leading to chronic problems.
And the complications sound quite extensive.
They can be, unfortunately. Infants with BPD can experience ongoing issues like intermittent bronchospasm, similar to asthma attacks. They often have persistent difficulty being weaned completely from the ventilator or supplemental oxygen. They're prone to recurrent respiratory infections like pneumonia or ear infections. In severe cases, it can lead to congestive heart failure. They're also at higher risk for developmental delays, cerebral palsy, hearing loss, and ROP. And sadly, there's an increased risk of sudden, unexpected death in infancy.
How do nurses assess for BPD? What do they look for?
During assessment, nurses continue to look for signs of respiratory distress, like protractions. When listening to the lungs, they might hear wheezes, rales, or rhonchi. They monitor for persistent hypoxia, needing ongoing oxygen, and sometimes respiratory acidosis on blood gases. These infants might also show signs of bronchospasm, as I mentioned, and sometimes fluid intolerance, difficulty handling fluids without getting congested. Chest x-rays typically show characteristic changes like an enlarged heart, overinflated lungs, and sometimes infiltrates or scarring.
What's the nursing care like for an infant who develops BPD? It sounds like it requires long-term management.
It does. Nursing actions include carefully providing and managing mechanical ventilation and oxygen administration according to orders, with the ultimate goal always being to gradually and patiently wean the infant off support as their lungs mature. Chest physiotherapy techniques to help loosen and clear secretions from the lungs is often crucial.
What about fluids and meds?
Fluid management is very precise. The goal is usually to provide maximal calories for growth with minimal fluid volume to avoid overloading the lungs and heart. Nurses administer prescribed medications, which might include bronchodilators to help open airways, corticosteroids, sometimes inhaled, to reduce inflammation, and diuretics to help manage fluid balance. Monitoring intake and output very closely is essential. And really, a key treatment component for BPD is simply time. Allowing the lungs as much time as possible to heal, repair, and grow is critical. Some infants with severe BPD may even go home requiring oxygen or, in some cases, with a temporary tracheostomy.
That's incredibly intensive long-term care. Let's touch on something that sounds perhaps a bit less severe, but is still a common respiratory challenge. Transient tachypnea of the newborn, or TTN.
Right, TTN is actually quite common and often seen in full-term or near-term infants. It's particularly common in babies delivered by cesarean section, especially elective C-sections where the mother didn't go into labor.
Why C-sections?
Because they don't experience that natural mechanical squeeze during passage through the birth canal that helps push fluid out of the fetal lungs. TTN is essentially a temporary difficulty caused by retained fetal lung fluid right after birth. It typically appears within the first few hours of life, is temporary, hence the name transient, and usually resolves on its own within about 72 hours. It can happen at any gestational age, though.
What are the key assessment findings for TTN? How does it look different from RDS?
Nurses will observe tachypnea rapid breathing, sometimes up to 100 or even 140 breaths per minute, usually peaking around 6 hours of age. They might also see expiratory grunting, some nasal flaring, and perhaps mild cyanosis, often just around the mouth. If they listen to the lungs, they might hear crackles or slightly diminished breath sounds due to the retained fluid. But generally, the work of breathing isn't usually as severe as in RDS, and the oxygen requirement is often lower.
And the nursing interventions for TTN? Fairly straightforward.
Relatively, yes. The primary intervention is to administer supplemental oxygen as needed, usually just enough to maintain oxygen saturation within normal limits, typically above 90%. As you said, TTN usually self-resolves within 72 hours, as the baby gradually absorbs the excess lung fluid. However, the same rule applies. If the respiratory rate is consistently greater than 60 breaths per minute, oral feedings are generally withheld due to the increased risk of aspiration. They might need IV fluids temporarily.
Okay, now let's discuss meconium aspiration syndrome, or MAS. I know meconium is the baby's first stool, so this sounds like a potentially serious problem if they inhale it.
It is, yes. MAS occurs when a baby inhales amniotic fluid that contains meconium, their first stool into their lungs, usually during or shortly after birth. This typically happens in term, or more commonly post-term, infants.
What causes them to pass meconium before birth?
It's often related to fetal stress or hypoxia, lack of oxygen, just before or during labor. This stress can cause increased intestinal peristalsis, movement of the gut, and relaxation of the anal sphincter, leading to meconium being passed into the amniotic fluid. If the baby then gasps or takes breaths while still surrounded by this meconium-stained fluid, they can aspirate it.
And what happens once it's in the lungs?
Once aspirated, the thick, sticky meconium can cause several problems. It can physically obstruct the airways, often creating a ball valve effect where air can get in but has trouble getting out. This leads to air trapping and overinflation of parts of the lung, while other parts might collapse. Meconium is also very irritating to the lung tissue, causing chemical pneumonitis inflammation, and it can inactivate surfactant, leading to problems similar to RDS. Severe MAS can also lead to persistent pulmonary hypertension of the newborn, PPHN, a very serious condition where the lung blood vessels remain constricted after birth.
What are the signs nurses look for if MAS is suspected?
They might have noted signs of fetal distress during labor, like abnormal heart rate patterns or the presence of thick meconium when the water broke. The baby's APGAR scores are often low at 1 in 5 minutes. Immediately after birth, they'll show clear signs of respiratory distress, cyanosis, rapid breathing, significant retractions. Their chest might appear overdistended or barrel-shaped due to air trapping. When listening, breath sounds could be diminished or coarse, with rales and raunchy. And visibly, you'll often see yellow or greenish staining of the skin, the fingernails, and the umbilical cord from the meconium.
And what are the nursing interventions here, particularly right at delivery if meconium is seen?
This has evolved a bit, but standard practice now, if meconium is present in the amniotic fluid and the baby is born vigorous, good tone, good respiratory effort, it's usually just routine care, including suctioning the mouth and nose as needed after delivery. However, if the baby is born depressed, poor tone, inadequate breathing, and there was meconium fluid, the recommendation is often still to immediately visualize the vocal cords with the laryngoscope and suction any meconium directly from the trachea before stimulating the baby to breathe or providing positive pressure ventilation.
So trying to clear the airway first.
Exactly. After initial stabilization, oxygen is administered as needed to maintain adequate saturation. These babies often require significant respiratory support, potentially including mechanical ventilation, high-frequency oscillatory ventilation, HFOV, or even ECMO, that heart-lung bypass machine in the most severe cases. Treatments like surfactant administration and inhaled nitric oxide might also be used to manage lung disease and pulmonary hypertension. Routine chest physiotherapy can also help clear secretions later on.
Now that we've covered the critical respiratory system in detail, let's broaden our view again to other vital body systems that are often impacted by prematurity and other complications. The newborn body is such an intricate network, and issues in one area can so easily cascade, can't they?
Indeed, they really can, especially in premature infants, where so many systems are still developing and maturing simultaneously. Let's maybe look at the cardiovascular and neuromuscular systems first, as they're closely linked to prematurity.
Okay. How does prematurity affect the heart and circulation specifically?
A key issue in premature infants relates to the blood vessels in their lungs. They often have an incomplete muscular coat. This leads to lower resistance in the pulmonary circulation after birth compared to a term infant. This lower resistance can cause a condition called patent ductus arteriosus, or PDA, to persist.
Remind us what the PDA is again?
The ductus arteriosus is a normal blood vessel connecting the aorta and the pulmonary artery in the fetus. It allows blood to bypass the fetal lungs. Normally, it closes functionally within hours or days after birth as the baby starts breathing air. But in preemies, especially very premature ones, it often remains open or patent.
And what are the consequences of that PDA staying open?
An open PDA allows oxygenated blood from the aorta to flow back into the pulmonary artery and lungs a left-to-right shunt. This extra blood flow floods the lungs, leading to pulmonary congestion, which makes breathing harder, increases respiratory effort, and can lead to carbon dioxide retention. It's extra workload on the heart as well.
What signs would a nurse assess for that might indicate a significant PDA?
On assessment, nurses might hear a characteristic heart murmur, often described as machine-like, although sometimes murmurs can be normal initially. They might feel an active precordium, meaning the chest wall over the heart feels very active or bounding. They might note bounding peripheral pulses, especially in the femoral arteries. The baby might also have tachycardia, fast heart rate, tachypnea, fast breathing, maybe recurrent episodes of apnea or bradycardia, increased work of breathing overall, and often difficulty being weaned from ventilator support. These are all signs that the PDA is hemodynamically significant, causing problems.
And how is it managed?
Medical management usually starts with an echocardiogram to confirm the presence and size of the PDA and assess its impact. Initial treatment might involve fluid restriction and diuretics to help reduce the fluid load on the lungs. If that's not enough, medications like indomethacin or ibuprofen might be given, which can help constrict and close the ductus. If medical management fails or isn't appropriate, surgical ligation tying off the PDA might be necessary.
And nursing actions.
Nursing actions focus on supporting the infant through this. That includes administering oxygen and managing ventilation as needed, monitoring fluid intake and output extremely closely, administering the medications as ordered, watching for side effects, and preparing the infant and family for surgery if that becomes the plan. It's worth noting that PDAs can take up to 3 days normally to close, but it's much less likely to close spontaneously in very premature infants.
Okay, so that covers a major cardiovascular issue in preemies. What about the neuromuscular system? You mentioned risks there too.
Absolutely. The neuromuscular system in premature infants is characterized by immature control over vital functions. The brain centers that regulate breathing, heart rate, and temperature are just not fully developed. This immaturity significantly increases their risk of intraventricular hemorrhage, or IVH.
The bleeding in the brain you mentioned earlier.
Exactly. And it also increases the risk of apnea, those pauses in breathing we discussed. Clinically, nurses will assess for poor muscle tone, often described as hypotonia. The baby feels floppy. They'll check reflexes, which might be weak or absent, and listen to the cry, which is often weak and feeble compared to a term infant.
Intraventricular hemorrhage sounds particularly frightening. What exactly causes it in these fragile infants?
IVH is primarily caused by the rupture of very thin, fragile capillaries located in a specific area near the ventricles of the brain, called the germinal matrix. This area is very rich in blood vessels in premature infants, but involutes later in gestation. These vessels are susceptible to rupture due to fluctuations in blood pressure or blood flow, often associated with hypoxia, respiratory distress, or even just routine handling or procedures in very fragile infants. The bleeding occurs into the ventricles, the fluid-filled spaces in the brain, and can increase pressure inside the skull.
What are the key assessment findings nurses look for if they suspect IVH?
Key assessment findings include neurological changes, maybe sudden hypotonia, lethargy, or even seizures. A bulging anterior fontanelle, the soft spot on top of the head, is a classic sign of increased intracranial pressure. Nurses will also measure head circumference frequently, as a rapidly increasing occipitofrontal circumference can indicate accumulating fluid or blood. Bradycardia, slow heart rate, and a recurrent apnea can also be signs. A significant unexplained drop in the baby's hematocrit or blood count might also signal a bleed.
And if a bleed is worsening?
If a bleed is worsening, you might see more severe symptoms like worsening seizures, increased frequency or severity of apnea episodes, and an increased need for ventilatory support.
Are there different severities or grades of IVH?
Yes, IVH is typically graded from 1 to 4, based on the location and extent of the bleeding seen on head ultrasound. Grades 1 and 2 involve smaller amounts of bleeding, usually confined to the germinal matrix or ventricles, without causing them to dilate significantly. These often resolve with few or no long-term problems. Grades 3 and 4 are more severe. Grade 3 involves enough blood to cause the ventricles to dilate, and Grade 4 involves bleeding that extends into the surrounding brain tissue itself. These more severe grades carry a higher risk of long-term neurological complications and may lead to hydrocephalus, requiring shunts to drain excess fluid.
What are the nursing actions aimed at trying to prevent or minimize the risk or severity of IVH?
The nursing focus is largely on minimizing rapid fluctuations in cerebral blood flow and avoiding sudden increases in intracranial pressure, as these can trigger or worsen bleeding in vulnerable infants. This involves things like minimizing environmental stimuli, keeping noise levels down, dimming lights. Handling the baby very gently and clustering care activities to allow for rest periods is important. Keeping the baby's head of the bed flat or only slightly elevated, unless there's respiratory distress requiring elevation, is often recommended. Administering intravenous fluids very slowly and carefully using infusion pumps helps prevent sudden shifts in blood volume and pressure. And as always, maintaining that neutral thermal environment is crucial to reduce overall physiological stress on the baby's system.
Let's move from the brain down to the gut. Necrotizing enterocolitis, or NEC, sounds like a very serious intestinal issue.
NEC is indeed an urgent and potentially devastating condition. It's an inflammatory disease that causes inflammation and necrosis, or tissue death, of the bowel wall, primarily affecting premature infants, usually occurring after they've started receiving feedings.
What puts preemies at higher risk?
Several factors contribute. Prematurity itself means an immature gut barrier, altered immune responses, and potentially decreased intestinal motility. The underlying cause is often thought to involve decreased blood flow and oxygen perfusion to the intestines, perhaps related to hypoxic events around birth or episodes of low blood pressure or poor circulation afterwards. When feedings are introduced into this potentially compromised gut, it can trigger an inflammatory cascade leading to tissue damage.
What are the assessment findings that would make a nurse suspect NEC?
Nurses watch very closely for specific signs. Abdominal distension is a key, finding the belly becomes swollen and tense. Nurses will often measure abdominal girth regularly to track this. Poor feeding tolerance is another major sign this might manifest as decreased bowel sounds, frequent vomiting, sometimes bile-stained, or large amounts of undigested milk left in the stomach before the next feeding, increased residuals. The presence of blood in the stool, either visible or occult, is another red flag. Systemically, the baby might become lethargic, have apnea and bradycardia spells, temperature instability, either high or low, signs of poor perfusion like cool extremities or delayed capillary refill, and sometimes the abdomen itself might develop a dusky or discolored appearance.
What's the immediate treatment if NEC is suspected? It sounds like time is critical.
Time is absolutely critical. The very first action is to make the infant NPO nothing by mouth, immediately stopping all enteral feedings to rest the bowel. This is followed by starting intravenous fluids to maintain hydration and nutrition. Gastric decompression, usually with a tube placed into the stomach connected to low intermittent suction, helps remove air and fluid from the bowel. Broad-spectrum prophylactic antibiotics are started to cover potential infection, which often accompanies NEC. And in many cases, especially if there's evidence of perforation or worsening clinical status despite medical management, urgent surgery is required to remove the dead or necrotic portions of the bowel.
Another complication we touched on briefly, often related to prematurity and its treatments, is retinopathy of prematurity, or ROP, affecting the eyes. What's the connection there, especially with oxygen?
ROP is a significant concern, particularly for very premature infants. The primary issue is that the retina, the light-sensitive tissue at the back of the eye, isn't fully vascularized. The blood vessels haven't finished growing to the periphery in a premature baby. Exposure to various stressors, including historically prolonged exposure to high concentrations of supplemental oxygen, can disrupt this normal vascular development. It can cause abnormal blood vessels to grow, which are fragile, can leak fluid, cause scarring, and in severe cases lead to retinal detachment and permanent vision loss.
So oxygen is a major risk factor, but are there others?
Yes, while careful oxygen management is key, other risk factors for ROP include severe IVH, chronic lung disease, BPD, recurrent apnea and hypoxia, sepsis, acidosis, being part of a multiple gestation, exposure to very bright lights in the NICU, and sometimes even blood transfusions have been implicated. It's complex.
How is it managed or screened for?
Because the risk is significant, all preterm infants born below a certain gestational age or birth weight, often 30 weeks or 1,500 grams, or slightly larger infants with complicated medical courses who received oxygen undergo routine screening eye exams by an ophthalmologist, starting several weeks after birth and continuing until the retinal vessels are fully mature. Fortunately, most cases of ROP are mild and regress spontaneously without treatment. Severe cases, however, might require treatment like laser therapy or injections of medication into the eye to prevent retinal detachment.
What are the key nursing actions related to ROP prevention?
Nursing actions primarily focus on meticulous management of oxygen therapy. This means maintaining oxygen saturation levels strictly within the parameters ordered by the medical team, avoiding wide fluctuations. Using oxygen blenders to deliver precise concentrations of oxygen is standard practice. While evidence is debated, minimizing exposure to overly bright ambient light in the NICU is also often practiced as a precaution.
Okay. Let's circle back to apnea of prematurity, which you mentioned in the context of the immature neuromuscular system. Can you define that more clearly?
Certainly. Apnea of prematurity is formally defined as a cessation of breathing that lasts for more than 20 seconds. Or it can be a shorter pause in breathing, less than 20 seconds, but one that is accompanied by either bradycardia, a significant drop in heart rate, typically below 80 or 100 beats per minute depending on the definition used, or oxygen desaturation, usually defined as saturation falling below 85%.
And what's the underlying cause in preterm infants?
The primary reason is the immaturity of the central nervous system, specifically the breathing control center located in the brainstem. It just doesn't send consistent signals to breathe yet. Contributing factors can include poor neuromuscular control of the chest wall and airway muscles and general instability of the upper airway, which can collapse more easily.
Are there other things that can trigger apnea episodes?
Yes, other conditions can worsen or trigger apnea in a susceptible preemie. Things like having an obstructed airway, for example from secretions or poor positioning, underlying infection, hypothermia or cold stress, gastroesophageal reflux or metabolic disturbances can all play a role.
How does it present? What do nurses observe?
During an apneic episode, nurses might observe pallor, the baby looks pale, a dusky skin tone, or frank cyanosis, bluish discoloration, especially around the mouth and extremities, along with the absence of breathing movements and the drop in heart rate or oxygen saturation shown on the monitor.
What are the key nursing interventions for managing apnea of prematurity?
Continuous cardiorespiratory monitoring heart rate and breathing is absolutely essential for all infants at risk. Often this is done with an apnea monitor that alarms if thresholds are breached. Nurses focus on maintaining a clear, patent airway through proper positioning and gentle suctioning if needed.
What do they do if an episode occurs?
If an apnea episode occurs, the first step is usually to provide gentle, tactile stimulation, maybe rubbing the baby's back or flicking the soles of their feet, which is often enough to startle them back into breathing. Repositioning the infant can also help. Ensuring feedings are given slowly and pacing the infant can help prevent apnea related to feeding fatigue or reflux. Supplemental oxygen may be needed if episodes are frequent or severe. And providing education and support to the family about apnea is crucial.
Is there medical management too?
Yes, for frequent or severe apnea, medical management often involves medications called methylxanthines. Caffeine citrate is the most commonly used drug now. It acts as a central nervous system stimulant, specifically targeting the respiratory center to promote more regular breathing. Theophylline was used previously but has more side effects.
What's the immediate action nurses take if a baby has significant apnea accompanied by bradycardia?
If gentle tactile stimulation is unsuccessful in resolving the apnea and bradycardia, the next steps are usually to reposition the infant, ensure the airway is clear, and if necessary, provide positive pressure ventilation using a manual resuscitation bag and mask until the baby starts breathing effectively on their own. Supporting respiratory function almost always leads to normalization of the heart rate.
That's a thorough overview of the systemic impacts of prematurity. You mentioned earlier that we can't cover every single congenital anomaly, but could you briefly touch on a few other common ones nurses need to be aware of and assess for?
Absolutely. It's important to recognize the variety. For example, developmental dysplasia of the hip, or DDH, where the baby's hip joint hasn't formed correctly and might be dislocated or unstable. Being in a breech position in the womb is a significant risk factor. Nurses assess for this using specific maneuvers called the Ortolani and Barlow tests, and also look for signs like uneven skin folds on the thighs or buttocks, or a difference in leg length. Interventions often involve keeping the hips in a flexed, abducted position, sometimes using a special brace called a Pavlik harness.
What about neural tube defects?
Neural tube defects, like myelomeningocele or meningocele, occur when the spinal cord doesn't close properly during early pregnancy. Folic acid deficiency before and during pregnancy is a major preventable cause. These defects often come with other complications, like hydrocephalus, fluid buildup in the brain. Nursing interventions are critical immediately after birth, protecting the exposed sac with sterile, moist dressings, positioning the baby prone or side-lying to avoid pressure on the defect, preventing infection, and providing immense family support. These and many others, like cleft lipolate or gastrointestinal defects, really highlight the complexity and the need for specialized holistic care from the moment of birth.
We've journeyed through many physical and systemic complications, but now let's shift focus to a critical metabolic balancing act that's incredibly common in newborns and requires keen nursing assessment and intervention: jaundice.
Yes, jaundice, or hyperbilirubinemia, is that yellow discoloration of the skin and eyes that many newborns display. It's caused by a buildup of bilirubin, which is a yellow pigment produced during the normal breakdown of red blood cells. While some jaundice is normal, the critical concern, the potential complication we always want to prevent, is kernicterus.
Kernicterus sounds serious.
It is extremely serious. Kernicterus is a devastating and usually preventable form of brain damage that can occur when the level of unconjugated or indirect bilirubin gets excessively high in the blood. This type of bilirubin can cross the blood-brain barrier and deposit in specific areas of the brain, particularly the basal ganglia, causing permanent neurological impairment, things like cerebral palsy, hearing loss, and developmental delays. The risk of kernicterus increases with very high bilirubin levels, lower gestational age, the infant's overall clinical condition, and factors like poor fluid intake or caloric balance.
So, with that risk in mind, how do nurses differentiate between what's considered normal or physiologic, jaundice, and something much more serious, pathologic jaundice? This distinction feels absolutely crucial, especially related to our objective on differentiating the two.
This is indeed a cornerstone of neonatal assessment. Physiologic jaundice is incredibly common, affecting maybe 60% of term infants and even more preemies. It occurs because a normal newborn has a higher concentration of red blood cells than an adult. These fetal red blood cells have a shorter lifespan, so more breakdown, and the newborn's liver is still immature and not fully efficient at conjugating bilirubin, processing it into a form that can be easily excreted.
What's the key timing for physiologic jaundice?
The key differentiator for physiologic jaundice is its timing. It begins appearing after the first 24 hours of life. Bilirubin levels typically rise gradually, peaks somewhere between day 3 and day 5 in term infants, maybe a bit later, day 5-7 in preterm infants, and then gradually decline. Factors that can increase the risk or severity of physiologic jaundice include significant bruising from birth, like cephalhematoma, underlying infection, delayed feedings, which slows down stooling, and delayed clamping of the umbilical cord, which increases the red cell load.
Okay, after 24 hours is physiologic. So what about pathologic jaundice?
Pathologic jaundice is the type that signals an underlying problem and requires more urgent investigation and intervention. It's usually related to excessive breakdown of red blood cells, a condition called hemolysis. This is often due to hemolytic disease of the newborn, caused by Rh incompatibility. Mother is Rh negative, baby is Rh positive, or ABO incompatibility, e.g. mother is type O, baby is type A or B.
And the timing here.
The defining characteristic of pathologic jaundice is its timing. It appears within the first 24 hours of life. That's a major red flag. Additionally, bilirubin levels in pathologic jaundice tend to rise much more rapidly, often defined as an increase of more than 5 milligdl in 24 hours, or more than 0.2 milligdl per hour. It may also persist for longer than expected, or be associated with other signs of illness. Rh incompatibility, historically called erythroblastosis fetalis, can be particularly severe, causing significant anemia, heart failure, generalized edema, hydros fetalis, and hypoxia. ABO incompatibility usually causes less severe hemolysis, but is actually more common. So that onset time within 24 hours is the most critical initial differentiator suggesting pathology.
What about jaundice related specifically to breastfeeding? That seems like a separate category almost.
Yes, we often talk about two types of jaundice associated with breastfeeding, and it's important to distinguish them. First, there's breastfeeding jaundice, sometimes called early onset jaundice or lack of breastfeeding jaundice. This typically occurs within the first few days of life, maybe days 2 to 4. It's primarily due to ineffective breastfeeding, leading to inadequate milk intake.
How does poor feeding cause jaundice?
If the baby isn't getting enough milk, they don't stool or urinate as frequently, which slows down the excretion of bilirubin from the body. It can also lead to dehydration, concentrating the bilirubin. The intervention here isn't to stop breastfeeding, but rather to focus on improving latch, increasing feeding frequency 8-12 times a day, and ensuring adequate milk transfer. Sometimes temporary supplementation with express breast milk or formula might be needed if intake is significantly low.
And the other type?
The other type is breast milk jaundice, which is late onset. This typically appears after the first week of life, often peaking around 2 weeks, and can sometimes persist for several weeks or even months, though usually at lower levels. This type is thought to be associated with certain substances present in some mother's breast milk that may interfere with bilirubin processing or increase its reabsorption from the intestine. It's a diagnosis of exclusion, meaning other causes have been ruled out. In most cases, breastfeeding can and should continue, as the jaundice is usually harmless unless bilirubin levels become excessively high, in which case a temporary interruption of breastfeeding might be considered under medical guidance.
That's a helpful distinction. So how do nurses actually assess for jaundice? What are they looking for beyond just the yellow color?
Assessment starts with identifying risk factors: prematurity, bruising, family history, maternal blood type. Knowing the blood type and Rh factor for both mother and infant is crucial, especially if a mother is Rh negative or blood type O. Coombs tests are important here too. The indirect Coombs test is done on the mother's blood prenatally to check for antibodies against fetal red blood cells. The direct Coombs test is done on the infant's cord blood or blood after birth to detect if maternal antibodies are actually attached to the baby's red blood cells, indicating hemolysis is likely.
And the physical assessment.
For the physical assessment, nurses visually assess for jaundice by gently pressing on the baby's skin, usually over a bony prominence like the sternum or forehead, in good natural light. When you release the pressure, blanching occurs, and if jaundice is present, the underlying skin will look yellow. Jaundice typically progresses in a head-to-toe fashion, so noting how far down the body the yellow extends can give a rough estimate of the level. For dark-skinned infants where skin assessment is harder, nurses focus on checking the sclera, the whites of the eyes, the mucous membranes inside the mouth, and the palms of the hands and soles of the feet for yellowness.
In measuring the levels.
Visual assessment is subjective, so objective measurement is key. Nurses often use a transcutaneous bilirubinometer, TCB, a handheld device placed on the baby's forehead or chest that estimates the bilirubin level through the skin. If the TCB reading is high, based on the baby's age and hours and risk factors, it's usually confirmed with a blood test for total serum bilirubin, TSB.
If an infant does have significant jaundice requiring treatment, what are the interventions? I know phototherapy is very common. This relates directly to the objective about nursing responsibilities during phototherapy.
Right. The first-line intervention for many cases, especially physiologic and early-onset breastfeeding jaundice, is actually optimizing feeding, encouraging early and frequent feedings to promote stooling and urination, which helps excrete bilirubin. If bilirubin levels rise above a certain threshold, which depends on the baby's age, gestation, and risk factors, then phototherapy is the mainstay of treatment.
How does phototherapy work?
Phototherapy uses specific wavelengths of blue-green light. This light is absorbed by the bilirubin accumulated in the baby's skin. It changes the shape and structure of the bilirubin molecule into isomers that are water-soluble and can be excreted in the bile and urine without needing to be conjugated by the liver. It essentially provides an alternative pathway for elimination.
So what are the specific nursing responsibilities when caring for an infant under phototherapy lights?
There are several critical nursing responsibilities. First and foremost is eye protection. The infant's eyes must be covered with special opaque eye patches or shields while under the lights to prevent potential retinal damage. These eye covers should fit snugly but not too tightly, and they need to be removed periodically, usually every couple of hours, perhaps during feeding or cares when the lights are temporarily off, to assess the eyes for any irritation, discharge, or pressure sores, and also to allow for eye contact and bonding between the baby and parents.
What about skin exposure?
Maximal skin exposure to the light is crucial for effectiveness. So the infant is usually undressed, wearing only a diaper. Sometimes specialized bikini diapers are used to expose more skin, with the genitalia typically covered, especially in males, though evidence on this is evolving.
And positioning.
The infant's position needs to be changed frequently, typically every 2 to 3 hours, to ensure all skin surfaces are exposed to the light over time. This also helps prevent skin breakdown from pressure. Nurses need to assess skin integrity regularly.
Does it affect their output?
Yes. Phototherapy increases insensible water loss through the skin and can cause loose, frequent, often greenish stools as the bilirubin breakdown products are excreted. So nurses need to monitor the frequency and consistency of stools and urine output closely. Maintaining adequate hydration is vital. Fluid intake often needs to be increased by about 20–25% to compensate for the increased losses and help flush out the bilirubin. This might mean more frequent breastfeeding or formula feeding, or sometimes supplemental IV fluids.
Temperature is always key too, right?
Always. The infant's temperature needs to be assessed frequently, typically every 2 to 4 hours, as they can become overheated under the lights or, conversely, get too cold if they're only in a diaper. The goal is maintaining that neutral thermal environment. And of course, bilirubin levels, usually TSB, are monitored regularly, perhaps daily or more often, to track the treatment's effectiveness and determine when phototherapy can be discontinued.
That's a very detailed breakdown of phototherapy care. What if the bilirubin levels are extremely high or rising very rapidly despite phototherapy?
In those critical situations where the risk of kernicterus is very high, an exchange transfusion might be necessary. This is a much more invasive procedure, reserved for severe hyperbilirubinemia, unresponsive to intensive phototherapy.
How does an exchange transfusion work?
It involves gradually removing small amounts of the infant's blood, which is high in bilirubin, and contains the antibodies causing hemolysis, if applicable, and replacing it with donor blood, usually type O Rh-negative low-titer blood that is cross-matched against the mother's serum, that is free of antibodies, and has normal bilirubin levels. This is done slowly, in cycles, often through umbilical catheters, over a couple of hours. The goal is to rapidly decrease the bilirubin level, remove harmful antibodies, correct anemia if present, and reduce the risk of brain damage.
What are the nursing responsibilities during that?
Nursing care during an exchange transfusion is incredibly intensive. Nurses meticulously assess vital signs, heart rate, respiratory rate, temperature, blood pressure before, continuously during, and frequently after the procedure. They precisely record all details: the time, the exact amount of blood withdrawn and injected in each cycle, and any medications given. Sometimes calcium gluconate is given to counteract citrate in the donor blood, which can lower calcium levels. They constantly assess the infant for potential complications, which can include cardiac arrhythmias, breathing difficulties, bleeding, electrolyte imbalances, infection, hypoglycemia, or hypothermia. Close monitoring continues for hours afterwards. Sometimes, administering intravenous immunoglobulin, IVIG, can help reduce the need for exchange transfusions in cases of isoimmune hemolytic disease.
Fascinating, and clearly a high-stakes procedure. Let's shift now specifically to the infant of a diabetic mother, or IDM. This seems like a unique set of challenges requiring specific care components, another key objective for us.
It definitely is a unique situation with specific risks. The underlying physiology is quite specific. Maternal insulin, which regulates the mother's blood sugar, cannot cross the placenta to the baby. However, glucose can and does cross freely.
So if the mother's blood sugar is high,
If a mother has diabetes, especially if it's not well controlled during pregnancy, her high blood glucose levels lead to high glucose levels in the fetus. In response, the fetal pancreas works overtime, producing and secreting much higher levels of insulin than normal.
what does all that extra fetal insulin do?
That fetal hyperinsulinism has several effects. First, insulin acts as a powerful growth hormone in the fetus, leading to increased growth, particularly of fat and muscle. This is why IDMs are often large for gestational age, LGA. Second, high insulin levels can interfere with the maturation of the lungs and decrease the production of surfactant, increasing the risk of respiratory distress syndrome, RDS, even if the baby is term or near term.
So an IDM is often a big baby, but paradoxically might have immature lungs and breathing problems. What other specific assessments are crucial for these infants?
Besides being LGA, nurses meticulously assess for signs of birth trauma, particularly related to shoulder dystocia, because of their large size. These infants often have enlarged internal organs, cardiomegaly, enlarged heart, hepatomegaly, enlarged liver, and splenomegaly, enlarged spleen, due to the growth effects of insulin. But the biggest immediate metabolic concern after birth is hypoglycemia,
Why hypoglycemia?
because immediately after birth, the constant supply of high glucose from the mother via the placenta is abruptly cut off when the cord is clamped. However, the infant's pancreas is still geared up to produce high levels of insulin. This mismatch, high insulin production with no incoming glucose supply, causes their blood sugar to drop rapidly and often significantly in the first few hours of life. They are also at increased risk for hyperbilirubinemia, jaundice, and polycythemia. There's even a slightly increased risk of certain congenital anomalies associated with pregestational diabetes.
So managing that hypoglycemia risk is key. What are the nursing interventions for IDMs, particularly related to blood sugar? This is a core component of their care.
Absolutely. Nurses perform a thorough assessment, checking carefully for any birth trauma. Critically, they assess blood glucose levels very frequently, starting soon after birth, typically within 30 minutes, and then at regular intervals according to hospital protocol, often at 1, 2, 4, 6, 9, 12, and 24 hours after birth, or until stable.
And what's done if the glucose is low?
The very first intervention for managing hypoglycemia is initiating early and frequent feedings, ideally with breast milk or formula, within the first hour of life. Feeding provides glucose. If the infant is unable to consume enough orally to maintain adequate glucose levels, or if the level is significantly low, the next step is often to administer a 40% dextrose gel buccally rubbed inside the cheek, which can be absorbed quickly and help raise blood sugar. If these measures aren't sufficient, or if the hypoglycemia is severe or symptomatic, then an intravenous infusion of D10W, 10% dextrose and water, is usually started.
That brings us directly to hypoglycemia in newborns more generally. What's the specific definition, and why is it such a dangerous condition for any newborn?
Hypoglycemia, in a term neonate, is generally defined as a blood glucose level less than 40 mg/dL. although some guidelines use slightly different cutoffs, especially for preterm infants. It represents a critical energy crisis for the newborn brain, which relies almost exclusively on glucose for fuel.
Which babies are most at risk besides IDMs?
Babies most at risk include, as we said, infants of diabetic mothers. Also SGA, small for gestational age, infants because they have inadequate glycogen stores. Premature infants for similar reasons, and immature regulation. Infants experiencing significant cold stress or hypothermia because they burn through glucose trying to stay warm. And any infant with delayed initiation of feedings. Prompt identification and treatment are crucial because severe or prolonged hypoglycemia can lead to seizures, permanent brain damage, and even death.
What are the warning signs nurses are looking for? Are they always obvious?
That's the challenge. The signs can be quite subtle and nonspecific. Assessment findings might include tremors or jitteriness, lethargy or difficulty waking for feeds, decreased muscle tone, hypotonia, pauses in breathing apnea, hypothermia, low body temperature, a weak or high-pitched cry, and poor feeding behavior. Sometimes babies can be dangerously hypoglycemic with very few outward signs.
So screening is important. What are the nursing interventions for hypoglycemia when it's detected in any newborn?
Nurses need to check the blood sugar, usually via heel stick, on all infants identified as being at risk, typically starting around 1 hour of age, or 30 minutes if the mother is diabetic, and also on any newborn exhibiting potential symptoms, regardless of risk factors. Treatment must be immediate if hypoglycemia is confirmed. As mentioned, initiating or encouraging breastfeeding or formula feeding is often the first step if the baby is stable and able to feed. If not, or if levels are very low, 40% dextrose gel is a common next step. If IV access is needed, D10W is typically used.
What if the baby is too lethargic to feed?
That's a critical safety point. It's vital not to attempt oral feeding in a lethargic or symptomatic infant due to the high risk of aspiration. In such cases, if IV access isn't immediately available or while it's being established, feeding via a nasogastric or orgastric tube, gavage feeding, might be necessary to provide glucose safely. After any intervention, blood glucose levels must be reassessed, usually before the next scheduled feeding, to ensure the level has normalized and remains stable.
We've explored many internal challenges and metabolic issues, but external factors, particularly maternal health status during pregnancy and delivery, play a huge role in determining newborn risk. Let's delve into the impact of maternal infections and substance abuse, focusing on the components of care related to these issues, as outlined in our objectives.
This is indeed a critical area, as many serious conditions in newborns are acquired either prenatally across the placenta, during labor and delivery, or shortly after birth from the mother or environment. We often categorize some key congenital infections, those present at birth, under the TORCH mnemonic.
Right, TORCH. Remind us what that stands for and the implications.
TORCH stands for toxoplasmosis, other, like syphilis, varicella zoster, parvovirus B19, rubella, cytomegalovirus, CMV, and herpes simplex virus, HSV. Each carries significant potential implications for the newborn. Toxoplasmosis, contracted from undercooked meat or cat feces, can lead to severe neonatal disorders like seizures, coma, microcephaly, small head, or hydrocephalus, fluid on the brain. Nursing interventions primarily focus on prevention through maternal education, emphasizing good hand hygiene, avoiding raw meat and cat litter, especially cleaning the box, and maybe avoiding garden soil during pregnancy.
Rubella.
Rubella, or German measles, if contracted by the mother, especially early in pregnancy, can cause congenital rubella syndrome, leading to things like congenital heart disease, intrauterine growth restriction, IUGR, cataracts, and hearing loss. Infants born with congenital rubella are infectious and require isolation precautions. Vaccination is key for prevention. Cytomegalovirus, CMV, is actually a very common virus, but if a primary infection occurs during pregnancy, it can be transmitted to the fetus and cause problems like anemia, jaundice, hydrocephaly, microcephaly, pneumonitis, and is a leading cause of non-genetic sensorineural hearing loss in children.
And herpes.
Herpes simplex virus, HSV, can be transmitted to the infant during passage through an infected birth canal if the mother has active genital lesions at the time of delivery. Neonatal HSV infection can be devastating, even lethal, affecting the skin, eyes, mouth, or disseminating to internal organs and the central nervous system. A cesarean section is usually recommended if active lesions are present during labor to prevent transmission. Understanding these risks is a key component of caring for newborns potentially exposed to maternal infections.
What about other common maternal infections like hepatitis B or STIs? How does that component factor into newborn care?
Hepatitis B transmission is effectively prevented post-exposure. Infants born to mothers who are hepatitis B surface antigen, HBsAg, positive, most receive both hepatitis B immune globulin, HBIg, which provides passive immunity, and the first dose of the hepatitis B vaccine within 12 hours of life. This regimen is highly effective.
And STIs.
Sexually transmitted infections contracted by the mother also pose risks. Untreated maternal syphilis can cross the placenta and cause congenital syphilis, which can manifest with various symptoms shortly after birth or later in infancy if untreated. Newborn assessment includes checking maternal serologic tests like VDRL or RPR, and sometimes testing the infant directly. Gonorrhea, if the infant is exposed during delivery, can result in neonatal sepsis, or more commonly, ophthalmia neonatorum, a severe eye infection that can rapidly lead to blindness if not treated. This is why routine eye prophylaxis with erythromycin ointment is given to virtually all newborns within a few hours after birth.
Does that ointment cover chlamydia too?
Yes. Erythromycin eye prophylaxis is also effective against chlamydia trachomatis, another common STI that can cause neonatal conjunctivitis, though often appearing slightly later than gonococcal, and also neonatal pneumonia. Candidiasis, or thrush, a fungal infection, can be acquired from the mother's vaginal yeast infection during birth. It typically presents as white patches on the infant's oral mucosa, tongue, cheeks, that look like milk curds but cannot be easily wiped away and might bleed if scraped. It's usually treated with an antifungal medication like nystatin oral suspension.
What about HIV?
For HIV/AIDS, the risk of mother-to-child transmission has been dramatically reduced with current strategies. This includes antiviral therapy, like zidovudine, for the mother during pregnancy and labor, elective C-section delivery in some cases, and antiviral medication for the infant for several weeks after birth. Breastfeeding is generally discouraged in settings where safe alternatives are available, as the virus can be transmitted through breast milk. Standard precautions are used by healthcare workers when caring for all infants.
So many potential infections, each requiring specific knowledge and interventions. Let's broaden the scope to sepsis in the newborn. That sounds like a generalized, urgent infection.
Sepsis is indeed a generalized bacterial infection that spreads rapidly through the bloodstream and can affect multiple organs. It's a major cause of morbidity and mortality, especially in preterm infants. We categorize it based on timing. Early onset sepsis, usually within the first 72 hours, often acquired vertically from the mother. Late onset, after 72 hours, often acquired horizontally from the environment or caregivers. And a very late onset, usually after a month, often in NICU graduates.
What factors increase the risk of newborn sepsis?
Common risk factors include prolonged rupture of membranes, typically considered 18 hours before delivery, maternal fever or infection during labor, like chordiomamnionitis, invasive procedures performed on the infant, like resuscitation or central line placement, prematurity itself, due to immature immune systems, known maternal colonization with certain bacteria like group B streptococcus, GBS, aspiration of infected amniotic fluid or even formula or mucus, and difficult or prolonged labor.
What does sepsis look like in a newborn? Are the signs obvious?
That's the danger. The signs are often very subtle and nonspecific, especially early on. They can mimic other conditions. Key assessment findings nurses watch for include temperature instability. The baby might have a fever, but more often in newborns, especially preemies, they become hypothermic, low temperature. Feeding intolerance is common. They might have decreased intake, abdominal distension, vomiting, or just poor sucking effort. Subtle behavior changes like lethargy, irritability, or even seizures can occur. Pallor or poor perfusion might be seen. Respiratory distress can develop or worsen progressively. Jaundice might appear or worsen. Initially, there might be tachycardia, fast heart rate, but this can be followed by concerning episodes of apnea and bradycardia as the infection progresses. Abnormal white blood cell counts, either very high or very low, are also important laboratory indicators.
How do nurses intervene if sepsis is suspected? It sounds like rapid action is needed.
Rapid action is crucial. The critical first step is to obtain necessary cultures to identify the causative organism, typically blood cultures, often a urine culture, especially for late onset, and sometimes a cerebrospinal fluid, CSF, culture via lumbar puncture to rule out meningitis before starting antibiotics. Once cultures are obtained, broad-spectrum intravenous antibiotics are started immediately based on likely pathogens. Intravenous fluids are often needed for circulatory support. Nurses then meticulously monitor vital signs, oxygenation, perfusion, feeding tolerance, urine output, and overall clinical status, observing closely for any changes or response to treatment.
Let's specifically discuss group beta streptococcus, or GBS, as it's a common bacteria screened for in pregnancy and a cause of early onset sepsis.
Right. GBS is a bacteria that commonly colonizes the genital and gastrointestinal tracts of healthy women without causing symptoms. However, it can cause severe life-threatening infection in newborns if transmitted during labor and delivery. Because of this risk, universal screening of all pregnant women via vaginal rectal swab is recommended around 35-37 weeks gestation.
And if a woman tests positive,
If a woman tests positive for GBS, or if she has certain risk factors, like having had a previous infant with GBS disease or GBS bacteriuria during the current pregnancy, she's treated with intravenous antibiotics, typically penicillin G, during labor. This significantly reduces the risk of transmission to the infant.
what if an infant develops symptoms despite this?
If an infant whose mother received intrapartum antibiotics still develops symptoms suggestive of early-onset GBS disease, which usually presents within the first 12-24 hours with respiratory distress, apnea, or signs of shock, or if the mother didn't receive adequate prophylaxis, then a full diagnostic workup is needed. This typically includes a complete blood count, CBC, blood cultures, and often a chest X-ray. Empiric antibiotics, usually ampicillin and gentamicin, are started promptly while awaiting culture results. These proactive screening and treatment strategies are vital components of preventing GBS sepsis.
That's a lot of critical information about managing maternal infections and their impact. Now let's explore the consequences of maternal substance abuse on the newborn. This is another key objective relating those consequences to the care needed. This must be an incredibly challenging and sensitive area.
It truly is, with complex medical, social, and ethical dimensions. One of the most significant direct consequences we see in newborns is neonatal abstinence syndrome, or NAS, also sometimes referred to as neonatal opioid withdrawal syndrome, NOWS, when specifically related to opioids.
What causes NAS?
NAS occurs because the baby has been chronically exposed to drugs, most commonly opioids like heroin, methadone, buprenorphine, or prescription painkillers, but also others like antidepressants, benzodiazepines, or stimulants that the mother was taking during pregnancy. These substances cross the placenta, and the fetus develops a physical dependency. After birth, when the supply is abruptly withdrawn, the baby experiences withdrawal symptoms. Maternal substance use during pregnancy also increases the risk of other adverse outcomes, like spontaneous abortion, preterm labor, placental abruption, IUGR, and stillbirth. The severity and timing of withdrawal depend heavily on the type of drug used, the dose, the frequency, the mother's metabolism, and how close to delivery the last dose was taken.
What are the typical signs of NAS or opioid withdrawal in a newborn? It must be very distressing to witness.
It can be very distressing. Nurses use standardized scoring tools, like the Finnegan Neonatal Abstinence Scoring System, FNS, to objectively assess the severity of withdrawal symptoms across multiple systems. Symptoms are wide-ranging and reflect central nervous system, hyperirritability, gastrointestinal dysfunction, and autonomic instability. You might see neurological signs like hyperactivity, jitteriness or tremors, increased muscle tone, exaggerated reflexes, difficulty sleeping, and sometimes seizures in severe cases. A characteristic sign is a very high-pitched, shrill, and incessant cry that's difficult to console.
What about other systems?
Gastrointestinal symptoms are common. Poor feeding, uncoordinated sucking, regurgitation or vomiting, loose stools or diarrhea leading to dehydration and skin breakdown of the diaper area. Autonomic signs include frequent yawning or sneezing, nasal stuffiness or congestion, sweating, fever or unstable temperature, and rapid breathing tachypnea. They often have frantic rooting but poor feeding coordination, and a strong need for non-nutritive sucking. These symptoms can significantly interfere with bonding and care.
How do nurses intervene for an infant experiencing NAS? What are the key components of care?
Nursing interventions are multifaceted, focusing on both pharmacological and non-pharmacological support. Non-pharmacological measures are always the first line. This includes minimizing environmental stimuli, keeping the room quiet and dimly lit. Swaddling the infant snugly provides comfort and security and can help reduce tremors. Providing opportunities for non-nutritive sucking with a pacifier can be very soothing. Positioning the infant on their side or with the head elevated after feeds can help with drainage if vomiting occurs. Small, frequent, higher-calorie feedings are often needed due to increased metabolic demands and feeding difficulties. Meticulous skin care is required due to risk of excoriation from loose stools or hyperactivity. Nurses monitor fluid intake and output and daily waste closely to assess hydration and nutrition. They also obtain meconium and/or urine samples for drug screening to confirm substance exposure and guide management. Promoting maternal bonding and involvement in care, often with support from social services, is also crucial.
What if non-pharmacological measures aren't enough?
If withdrawal symptoms are severe and significantly impacting the infant's feeding, sleep, or causing excessive weight loss, then pharmacological treatment is necessary. Morphine is generally considered the first-line medication for treating opioid withdrawal, NRWS. Methadone or buprenorphine might also be used, particularly if the mother was maintained on those medications during pregnancy. The dose is carefully titrated based on the withdrawal scores, aiming to control symptoms, and then slowly weaned over days or weeks. Phenobarbital might be added as a second-line agent if opioid treatment alone isn't sufficient, or sometimes used for withdrawal from non-opioid substances like benzodiazepines or alcohol, although diazepam is contraindicated in jaundiced newborns due to bilirubin displacement risk. These interventions directly relate to managing the consequences of maternal substance abuse.
What about fetal alcohol syndrome, or FAS? That's another consequence of maternal substance use.
Yes, fetal alcohol syndrome is part of a spectrum of disorders. Fetal alcohol spectrum disorders, FASD, caused by maternal alcohol consumption during pregnancy. Alcohol freely crosses the placenta and acts as a teratogen, interfering with fetal development, particularly brain development and protein synthesis. Unlike NAS, which is about withdrawal, FAS involves permanent birth defects and neurodevelopmental problems. There is no known safe amount of alcohol during pregnancy.
What are the characteristic features nurses assess for in FAS?
Infants with classic FAS are often SGA, small for gestational age. They have a distinct pattern of facial features, which can include small eye openings, palpebral fissures, a smooth philtrum, the groove between the nose and upper lip, and a thin upper lip. They may also have other physical anomalies. Neurologically, they are often irritable, hyperactive, have feeding problems, persistent vomiting, and a high-pitched cry. Long-term consequences include intellectual disability, attention deficits, learning disabilities, and behavioral problems.
And nursing interventions for FAS.
Nursing interventions for infants with FAS in the immediate newborn period often focus on managing the withdrawal-like symptoms they can exhibit, such as irritability and feeding difficulties. This includes reducing environmental stimuli, swaddling for comfort, potentially administering sedatives like phenobarbital if irritability is severe, and focusing on maintaining adequate nutrition and hydration, which can be challenging due to poor feeding. Long-term management requires a multidisciplinary approach involving developmental specialists, therapists, and educational support, along with strong family support systems.
We've covered such a vast landscape of high-risk newborn care, from early assessments and interventions for maturity and size, through respiratory, metabolic, infectious challenges, and the impacts of maternal substance use. But before we wrap up this deep dive, it's really important to acknowledge one more critical area: the physical trauma that can unfortunately occur during the birth process itself, and maybe equally importantly, the crucial role of supporting families through these incredibly intense and often unexpected beginnings.
Absolutely. Birth trauma, or birth injury, while less common now with improved obstetric care, can still occur even with skilled providers. These injuries happen during labor or delivery and can range from minor bruising to more significant problems. They can involve the skull or scalp, like cephalehematomas or caput succedaneum, intracranial bleeding, like subdural or subarachnoid hemorrhages, often related to difficult deliveries, spinal cord injury, very rare, or damage to peripheral nerves.
What nerves are commonly affected?
The brachial plexus nerves in the shoulder are probably the most common site of nerve injury, often resulting from excessive stretching during delivery of the shoulders, particularly in cases of shoulder dystocia with large babies. Cranial nerves, especially the facial nerve, can also be injured due to pressure, perhaps from forceps.
What are the risk factors that might predispose an infant to birth trauma?
Risk factors often relate to difficult deliveries. These can include advanced maternal age, fetal macrosomia, a very large baby, cephalopelvic disproportion, CPD, where the baby's head is too large to easily fit through the mother's pelvis, prolonged or very rapid labor, abnormal fetal presentation, like breech, and operative deliveries involving forceps or vacuum extraction.
When assessing a newborn, what findings might suggest a birth injury occurred?
Nurses look for specific signs. Generalized findings might include flaccid muscle tone or asymmetry of tone or movement. An absent or asymmetrical Moro reflex, the startle reflex, is a key sign suggesting potential nerve injury or fracture. A weak cry could indicate neurological issues or respiratory compromise. Specific findings depend on the injury type.
Can you give us a few examples of specific birth injuries and their signs?
Certainly. We mentioned facial paralysis earlier. This is usually temporary, caused by pressure on the facial nerve, cranial nerve 7th, during delivery, maybe from forceps or the maternal pelvis. On assessment, the affected side of the face won't move when the baby cries. The forehead won't wrinkle, the eye may remain open, the corner of the mouth won't pull down. It typically resolves on its own over days or weeks. Herb Duchenne paralysis, or Erb's palsy, is the most common type of brachial plexus injury, affecting the upper arm nerves, C5, C6. It's often due to stretching or pulling the head away from the shoulder during a difficult delivery. The assessment finding is characteristic. The affected arm hangs limp at the baby's side, internally rotated with the elbow extended and wrist flexed, sometimes called the waiter's tip position. The Moro reflex will be absent or asymmetrical on that side, though the grasp reflex in the hand usually remains intact. Interventions include careful handling, intermittent immobilization initially, gentle range of motion exercises later to prevent contractures, and supporting the family. Most infants recover significant function over time.
What about fractures?
Fractures can also occur, with the clavicle, collarbone being the most frequently fractured bone during delivery, often associated with shoulder dystocia. Less commonly, the skull or long bones like the humerus or femur can be fractured. Assessment findings include visible deformity or bruising over the bone, limited spontaneous movement of the affected limb or area, sometimes a palpable crackling sensation, crepitus, over the fracture site, and often pain or crying with movement. An absent Moro reflex on the affected site is common with clavicle or humerus fractures. Management usually involves careful handling and immobilization.
Now, what about asphyxia at birth? Is that considered a trauma?
Birth asphyxia isn't typically classified as a physical trauma, like a fracture, but it's a critical event representing injury due to lack of oxygen. It means inadequate oxygen supply and blood flow to the tissues around the time of birth, failing to meet the body's metabolic needs. It can be caused by various factors disrupting oxygen exchange, like problems with the placenta or umbilical cord, severe maternal hypotension, or failure of the baby to initiate effective breathing after birth. It can be caused by non-reassuring fetal heart patterns during labor, very difficult deliveries, extreme prematurity, or aspiration of thick meconium.
How is asphyxia assessed and managed immediately?
The Apgar score is the primary tool for assessing the need for resuscitation immediately after birth. A score of 7-10 is generally considered normal. A score of 4 to 6 often indicates the need for some assistance, usually stimulation and perhaps supplemental oxygen. A score less than 4 necessitates immediate and full resuscitative efforts, according to neonatal resuscitation protocols, NRP. Interventions at delivery for an infant anticipated to be depressed might include positioning the baby in a head-down or neutral position and suctioning the airway immediately, placing them under a pre-warmed radiant warmer, drying and stimulating respiratory effort by rubbing the back and feet vigorously, and initiating positive pressure ventilation if breathing is absent or ineffective, followed by chest compressions and medications like epinephrine or volume expanders if needed, based on heart rate response. Naloxone, Narcan, might be indicated only if respiratory depression is suspected due to maternal opioid administration close to delivery, but is generally not used otherwise in initial resuscitation.
Finally, and this is so incredibly important, let's talk about supporting the families of these high-risk newborns. This entire experience must be an overwhelming emotional roller coaster for them.
It is absolutely an emotional landscape filled with profound challenges, uncertainty, and often grief, even if the baby survives. For parents who have a baby admitted to the neonatal intensive care unit, the NICU, the experience can significantly interfere with the expected process of attachment and bonding. Instead of celebrating a healthy arrival, they're often faced with fear, anxiety, guilt, anger, disappointment, and a deep disruption to their lives and their vision of parenthood.
What can nurses do to support families navigating the NICU?
Nursing actions here are deeply rooted in empathy, communication, and facilitation, orienting parents thoroughly to the often intimidating NICU environment. The equipment, the routines, the staff roles is crucial. Encouraging mothers who wish to breastfeed to begin pumping breast milk early and providing support for lactation is important. Facilitating physical contact, touching, holding, kangaroo care when stable, talking to the infant is vital for bonding whenever medically possible. Critically, nurses need to provide consistent opportunities for parents to ask questions, express their feelings and concerns without judgment, receive clear and honest updates about their baby's condition, and be involved in care decisions as much as possible. Recognizing parents as essential partners in the baby's care team is key.
And if the unthinkable happens and a family experiences the loss of their newborn?
Supporting families through perinatal loss and grief is one of the most challenging but essential aspects of this work. Grief is a complex individual process, and there's no single right way to respond. Nursing actions in this devastating circumstance focus on providing compassionate presence. Simply being there, listening without judgment, offering tissues, expressing sincere empathy and condolences, "I'm so sorry for your loss," can mean the world, It's important to refer to the baby by name, acknowledging their existence and personhood. Providing parents with private time to be with their baby, hold them, and say goodbye is crucial. Offering memorabilia, things like footprints, handprints, a lock of hair, photos can become treasured mementos. Connecting the family with resources like hospital chaplains, social workers, bereavement counselors, and community support groups is also a vital part of holistic care. This support acknowledges the depth of their loss and helps them begin the long journey of grieving.
Wow. We've covered so much ground today on the deep dive, really navigating the intricate and often challenging world of high-risk newborn care. We've explored that wide spectrum of vulnerability, haven't we? From the tiniest premature infants to those born post-mature, really delving into those critical nursing assessments that pinpoint risk right from the start.
And the vital interventions that can truly turn the tide. We talked about the importance of maintaining that crucial neutral thermal environment, preventing cold stress. We differentiated between physiologic and pathologic jaundice and outlined the nursing responsibilities for phototherapy.
Right, and we spent significant time understanding respiratory distress from RDS and BPD to TTN and meconium aspiration syndrome, plus discussing the specific components of care needed for infants of diabetic mothers and those sadly affected by maternal substance abuse.
It truly highlights the incredible precision, the rapid response, and the unwavering dedication required from healthcare professionals, particularly nurses, in these critical moments. The complexity of these tiny patients demands such a vast knowledge base, but also an incredible capacity for compassionate care, not just for the infant, but truly for the entire family unit experiencing this intense journey.
Absolutely. And while all the information we've discussed today might seem dense, maybe even a bit overwhelming, it really underscores both the intricate fragility and the remarkable resilience of new life. It's a powerful testament, I think, to the fact that even the tiniest fighters, when given the right support and expert care, can overcome immense odds.
Well said.
So for you, our listener, as we close this deep dive, here's a final thought to ponder. Considering everything we've discussed, the medical complexities, the environmental factors, the family impact, what systems or support networks do you believe are most crucial for these high-risk newborns, and importantly for their families, to not just survive these intense beginnings, but to truly thrive in the longer term? Think about that and join us next time on The Deep Dive.